Hi, Sharon.
Hello,
Welcome back.
same to you.
We're gathered today for a breast cancer Q&A webinar, continuation of a series of webinars discussing various aspects of breast cancer. The format is that it's a question and answer, as it has been in the past. Sharon has solicited questions from people in her community, social media community, who had questions about Paget's. And so she'll present the questions to me, and I'll do my best to answer them in ways that are clear and maybe concise, maybe not. This webinar will be 1 hour. It's typically 1.5 hours, but this particular topic will be a 1 hour webinar. It'll be made available to everyone online after this meeting. And there's also a corresponding publication that will also be included. So if there's something you missed from the presentation, it'll be available to you in written form and video form through social media within a few days.
Okay.
Any additional comments you want to make before we get started?
No, except I had experience with Paget, so
Actually, why don't we, before we get into the general questions, if you don't mind, would you share your own experience with Paget's?
well, biggest one is that the doctors don't recognize it. I spent 2.5 years. It's interesting because I have this Facebook friend from Canada whose parents are doctors. And through conversations with her, she's the one that brought it up and said that it sounded like that's what I had.
Mm.
So, but every time I asked doctors about it, they said it was eczema. And I didn't find out it was really Paget's till I saw you.
Mm.
And I didn't even have to mention it. You brought it up.
Mm.
And I wouldn't recommend it, but I didn't bother to get a biopsy because I was so sure by then that that's what it was, that I didn't need a biopsy. But it's very annoying. It's either it'll itch or it stings or mine was on the nipple, but I guess it can be other than on the nipple.
Yeah, we'll talk about that, the various presentations.
So, but yeah, well,
Your experience reflects the experience of most women who are diagnosed with Paget's disease, that they are diagnosed relatively late. Most physicians don't recognize it. It's an uncommon phenomenon. It's seen in about 1 out of 3% of breast cancers, 1 to 3% of breast cancers. But still, which is not common, but still, with all the women diagnosed with breast cancer these days, there should be some common experience, and we all learn about it in school. But until you've seen it in a live patient, it might not stick. And most physicians haven't seen it or haven't recognized it, and therefore it often tends to progress and until the patient's seen by a breast specialist. I've seen it many times, and so it's a very obvious finding to me, but it isn't to many people, that you said.
I wonder if, like everything else, I wonder if it's getting more common than it was in the past.
And the statistics haven't changed dramatically.
Oh, okay.
But the awareness has changed, and this is part of the process of making it aware so that, subsequent to this webinar, if someone hears of someone with this condition, and we'll talk about the presentation, it'll come to mind and they'll seek appropriate care. So why don't we start with you first?
What is Paget's?
Okay. So Paget's disease is a condition involving the nipple and or areola. It is a type of breast cancer that involves the skin primarily, although it can be associated, in fact, it's commonly associated with an underlying cancer in the breast. It's not necessary to have an underlying invasive cancer or non-invasive cancer in the breast. Paget's indeed can happen just within the nipple or just within the areola. But as I said, commonly what we see on the surface of the breast, on the nipple and areola, is an extension of a process that is started within the breast. That's the most common scenario. And so the typical situation is someone has either invasive or non-invasive breast cancer within the breast. The cancer cells grow up the inside of the milk ducts until they reach the skin of the breast, which would be the nipple or areola. And then it grows in the layer of the skin, in the surface of the skin, between the skin cells, from the nipple, potentially outward to the areola, or potentially outward beyond the areola to the skin.
In my case, it started out as a discharge. looked almost like I had had a baby and I was getting the colostrum again. And that's what made me question it.
Right, so, as I said, this is a process that ideally, Paget's is diagnosed when someone has had a screening study, like a mammogram, an ultrasound. They're found to have an early stage cancer in the breast, and then they're seen by someone, and we detect a subtle change of the nipple skin that suggests that it might be Paget's disease. That's the kind of optimal situation. But if the diagnosis of the underlying cancer is delayed, for example, the Paget's can progress further. And so initially, it may start just as you had with symptoms of itching of the nipple. Itching isn't required, but itching is a common complaint. The nipple looks normal, but it's a little itchy. Normal looking appearance of the nipple and areola.
Actually, mine was a discharge.
Okay,
I don't even think it itched until after that.
right. So I think what you're describing is there was condition of the abnormal ducts below, like cancer often presents with a nipple discharge. And so
Okay.
your first symptom was probably the discharge is likely a discharge from
The tumor.
the tumor involving the milk ducts below the nipple surface. And then subsequent to that, as the cancer continued to progress up the ducts to the surface of the nipple, you began to develop skin changes of the skin of the nipple. But for someone who doesn't have an underlying problem, where it's happening primarily in the skin surface, their first signs might be itching, and then a mild skin rash of the nipple, and then a more significant rash, even formation of an ulcer, because basically the epithelialized skin, the dry skin surface, may be replaced by these Paget cells, this cancer. And so you have an ulcer that forms because there's no normal skin surface covering of the nipple.
What do you do if you suspect Paget's?
Well, it's necessary to seek an evaluation. So starting with your primary care doctor, ideally, they should make sure you have recent breast imaging performed, because if you're, delayed with breast screening, as I said, it could be a manifestation of an underlying cancer that has progressed from the interior of the breast to the surface of the breast. But if the mammograms are done, and we'll get back to the presentation, but if the mammograms are done and there is just this nipple or areola change, then someone has to sort of think about what the possibilities are. Now, one reason why the diagnosis of Paget's is challenging is that it's a very uncommon condition. It happens in 1 out of 3% of people with breast cancer. Not 1 out of 3% of people, but 1 out of percent of people with breast cancer. So if you say 1 out of 8 people have breast cancer and 1% of those people have Paget's disease, you can see why it's
not seen very much.
But what is very common in many women and men is eczema. There are various benign skin inflammations. Eczema is defined as a dry, scaly, often itchy inflammation of the skin. And so you have a very common condition called eczema or dermatitis of the skin, and you have versus very rare condition. And it's natural for people to think that when these symptoms develop, that it's probably eczema, not.
That's what made it worse for me, is I already have eczema.
So it complicates it.
Yeah.
And there's some patterns that you can think about, like if you have eczema in other parts of the body, then if it develops in the nipple or areola, which is very common, then it's probably a part of your eczema skin pattern. But if there's no prior history of eczema and you have this new rash that develops in the breast, then the worry about Paget should be a little higher. If it's happening only in one breast and not in another breast, because commonly eczema happens in both sides of the body in the same pattern, then that would could make you think, well, maybe it's Paget's and not something else. There are other potential diagnoses as well, not just Paget's and dermatitis, but the most common competing diagnosis for Paget's is eczema. And so what do? Well, you need to see a provider. They need to think about your situation. Does she have a history of eczema? Does she have a history of allergies? with skin reactions. Okay, if that's true, then maybe the first thing you would do is just treat it with a topical solution. So you can try a topical steroid to see if it responds and heals like we typically see. Sometimes Pages will improve with steroids as well, but it usually will come right back and won't be a complete response. But if it responds in the expected time frame over 2 or 3 weeks using topical steroid, then that's probably eczema. But if it doesn't, then you have to continue the diagnostic workup further. And if it isn't clear, then the only way to definitively get to the answer is to perform some type of biopsy of the skin to make the diagnosis.
What's better, punch biopsy or a scrape? Does it matter which one?
Yeah, I think there is a difference in the quality of the biopsy. The skin, so you presented 2 scenarios. There's a third scenario, but the most common one that we do is a punch biopsy. If you ever done any baking of cookies, use a cookie, you have a cookie cutter. So there's a small, device about the diameter, about 1 or 2 or 3 millimeters in diameter. So very tiny cookie cutter type device that we can use to kind of pour through the nipple or the areola, the affected skin, to get a full thickness biopsy of the skin. It's narrow, it's not like a little round cylinder, but it gives us a full thickness of the skin so that can be submitted to the lab for testing. Because the Pages might be near the top, but also could be near the bottom of that cylinder. With the scraping, if you only scrape the surface, there's a higher chance you might get non-Paget cells, like normal skin cells, and miss the Paget cells that might be near the bottom. Now, if you have more advanced Pagets, it'll be easier to get cells with scraping. But if it's an earlier Pagets, like maybe not so much skin changes, but maybe nipple itching might be the most common situation, then in that case, it's more important to get a full thickness biopsy because the Paget cells might be near the bottom of the skin, not near the top of the skin. I'm sorry, there's one other. There's something called an incisional biopsy. Maybe you're at a doctor's office who doesn't have a punch biopsy tool, because there are special devices that we order, but they can take a skin incision, basically make a small kind of a wedge shaped incision of the nipple or the areola, the affected skin, full thickness, and then close that with a suture so that it's a straight line, it's cleanly closed. But that's a way that anyone with a scalpel can take a sample of the skin.
Does Paget always present with skin problems?
Well, the guy who named this condition, his name is Paget. He's French. I think it'd be Paget in French.
Probably.
But he was a surgeon and a pathologist who named several types of conditions, all of which had the name Pagets. There's Pagets of the breast or mammary Pagets. There's extramammary Pagets, meaning it happens in other parts outside of the breast, but it involves just like the skin of the genitalia. There's also something called Pagets of the bone as well. So Pagets, the term can apply to different organs, but mammary Pagets, what we're talking about today, is a skin surface problem that almost always starts within a nipple, almost always, not always, and then potentially progresses to involve the areola. There are 2 theories about how it develops. I gave you one theory, which is that it develops from the milk ducts leading to the nipple, and the cancer cells grow from the milk ducts up to the surface of the nipple. That's kind of the more common phenomenon. There's another phenomenon that comes, there's another explanation that it comes from sweat glands. It's a cancer that arises from sweat glands of the nipple or areolar surface. There are these cells called Toker cells, Toker, like poker, but it's Toker. And they have the potential to develop cancer. They're present within the skin, within the glands, sweat glands of the skin. And Toker cells are one potential reason why someone can develop Pages of the areola but not involve the nipple. Because it's coming from these cells within the areola, and the nipple was spared because it's not a condition of the milk ducts, it's a nipple of the areola skin. And there's probably maybe 10% of those and 90% of them arising from the nipple ducts.
Should a nipple be removed once it's been diagnosed with Paget's? My previous oncologist didn't bother to do so.
So the most common approach to this is to first, and the most important approach to this is to first do a diagnostic workup for cancer. Because before you can sort of focus on how to manage the nipple, you have to think about the extent of disease within the breast. Is there disease that's immediately behind the nipple that gave rise to the Paget's? Is there disease in the back of the breast that extended all the way up to the surface of the nipple? Is there disease in multiple quadrants of the breast? So it's a basic cancer workup to determine the extent of disease, because you have to deal with that as well as the scan finding. If it's one of these situations where it only involves the nipple and areola, and there's no detectable disease below, and that's a less common situation. But if it is that common situation, then you can limit the extent of the treatment to the affected area of the skin. That typically involves removal of the whole nipple, or if it involves the areola, removal of the nipple and areola. But there are case series of people that had a partial nipple removal or a partial areola removal. We do know that, recurrence can be a problem. And if you remove just a part of the nipple or a part of the areola, then there's a higher chance of recurrence in the remaining part of the nipple and areola.
I think you pretty much described this, but how can we differentiate eczema and Paget's? I've had a nipple issue for 5 to 6 months. Skin around my areola became flaky and dry. I have a cut at the junction of the areola and the nipple, and after applying ointment, it heals, but then comes back.
So, I discussed 2 main diagnoses, Paget's. There's also eczema, which is the most common. Eczema can be acute, meaning it's short in duration, it goes away. It could be chronic, meaning it stays and it persists and responds incompletely to the typical treatments. Certainly, if you have a history of eczema and your breast imaging is normal, then eczema is the most likely diagnosis. But if it's uncertain, the most important way to make a distinction is to do the biopsy. We talked about that already. But an example that was given where someone tried a topical agent first, it got better and then got worse. It could have gotten better because it's just, it's eczema, it responded, but being a severe case, it came back because it wasn't in complete treatment. So maybe she needs a different kind of a stronger topical agent, not just hydrocortisone, but maybe dexamethasone or some other stronger steroid to treat it. As I said, there are also situations where Paget's will respond temporarily. So if it persists, and the important take-home message here is that if it persists despite topical treatments, then the workup needs to continue, and most likely it would require a core biopsy or an incisional biopsy to document, rather to exclude Paget's, so that you can continue on with long-term treatments of the underlying condition. But there are other possibilities. It could be a squamous cell cancer. There's something called Bowen's disease, which is a type of skin cancer involving the nipple or areola. And it can be confused. So if you have a negative biopsy for Paget's disease, they could potentially show a positive biopsy for squamous cell carcinoma, which would be Bowen's disease. There are other benign conditions as well that someone can have, but that covers the most common scenarios.
Mine got really confusing because none of the steroid creams work on my eczema anyways, but my eczema is only on my hands, pretty much. Can Paget's be ruled out by just a visual/physical exam?
It cannot be ruled out by just the exam alone. You have to think about the context. We talked about the context, the patient's history, the pattern, if it responds. And so obviously that's more than just looking. You can't also rule it in just by looking. You can't say that's Paget's disease. I mean, you can have a very high probability of it. You don't always require a biopsy if you have a strong indication, like there's a cancer underneath the skin and now there's
Like in my
Paget's.
case.
Right, you don't need to do a biopsy to prove that it's Paget's. You can make that clinical judgment. But if the breast is otherwise normal, and you have this skin condition that looks that like it could be Paget's, in the absence of, you have to look, it's not just a matter of looking, it's a matter of context. If the context in responsiveness suggests that it's Paget's, then it should be biopsy to prove that so that you can manage it appropriately as a cancer diagnosis. If the context suggests that it's eczema and it responds like eczema responds, then you don't need to do a biopsy. You can be comfortable with that diagnosis.
What is your opinion on watch and wait? A clinical advice on a patient presenting with continued itching for a year, rash, patches, and scales for the last 4 months. No response to steroid creams, mammo, and ultrasound are normal, but I have extensive family history of breast cancer. Should I biopsy?
Well,
Sounds like you probably should.
watch and rate should not last for months and years. Watch and rate is like 4 to 6 weeks.
I just remember you told me with mine, if it wasn't cleared up in 3 months, then should get a biopsy.
Right, so, I mean, I think that if you have to think of the context, and so
Mhm.
if this is you have eczema in more parts of the body than just the breast, then you could look at the context and say, this is likely also eczema, so we'll give it a longer time period to see if it responds to topical treatments, to without a biopsy. But if you have only one breast involved, it involves a nipple, you have a family history of breast cancer, hopefully you've had recent imaging that's negative, but maybe not.
Well, that's what she said she did. She did have imaging and it was negative.
Right, then at least that can allow you to give you a little bit of breathing. But again, if you try topical things and it doesn't respond completely, so we generally say that you can take a topical steroid for about 2 to 3 weeks, because chronic use of topical steroid can weaken the skin and make it more prone to injury and infection. So we usually don't say take it for 6 months. We say take it for a trial, typically 2 to 3 weeks, to see if it responds. And if it doesn't, then I think that that's a situation where biopsy should be considered if it's not clearly Paget's, or when you should see a dermatologist for a stronger medication. And sometimes it's the systemic medication, it's not just a topical medication.
I thought it was interesting when you told me to wait 3 months. I thought to myself, I've already waited 2 years. Why am I going to wait 3 more months?
Yeah, I can't think of the context why I might have suggested 3 months.
Because you probably didn't know it'd been going on for 2 years.
Oh, well, maybe that's true.
It was just like the first time I ever saw you and you said, I think you have Paget's. And I said, I know I have Paget's. And then you told me, well, if it's not cleared up in 3 months, you need to get a biopsy. So it was no other addition to that.
Okay.
I have Paget's and I still haven't found a cream that will clear it up. I'm not giving up though. Has anyone successfully healed the nipple of Paget's? Mine is weepy or scabby over and it's difficult to wear a bra. Is there a topical cream that anyone has used to get rid of it? I don't think so.
Well, in the literature search I did leading up to the publication that I mentioned, I did not see any of therapies that were reported. Maybe they exist, but I did not encounter any situations where purely topical agents were effective at treating Paget's. We're assuming that this is isolated Paget's involving the nipple and skin and not the ducts below, because certainly anything more in the interior of the breast won't be treated effectively by topical. But there are types of squamous cell cancers that you can treat with a topical chemotherapy agent. There's a context for thinking that there might be something that helps Paget's, but I've not encountered anything that could be used. I know that there is a case series of something called photodynamic therapy. I don't want to get too much into treatment yet, but maybe we'll soon, where you apply something to the skin. It sensitizes the uh, the cells to UV light, and then you use a UV light to treat it. So it's a combination of this topical agent and this light therapy, which has been successful in some cases.
The only other thing that I've come across is I have come across a few ladies that told me they had Pagets, and then when they did the Herceptin, it went away.
Right, so it's you know, it is there are a couple of scenarios. So if you have Pagets that progressed so that the skin surface is replaced by cancer, initially it starts off as non-invasive cancer, but it can progress to invasive cancer at the surface of the nipple. Then that should respond just like chemotherapy can cause responses in other parts of the breast. It can shrink, it can disappear, it can return to kind of normal tissue, depending upon the responsiveness, especially for HER2 positive tumors. They tend to respond better to anti-HER2 therapy, and so you get these more dramatic responses where things heal. But the Paget's part, which is the non-invasive part, traditionally, non-invasive cancer does not respond very well to chemotherapy. So even though the invasive cancer may disappear, the non-invasive part tends to linger. It's just not dynamic and active enough to be very responsive.
So if the Herceptin took it or made it clear up, it may only be temporary.
Right. That, the first course of therapy would be the drug therapy. And then that should be followed either by surgery or radiation or something to treat the tissue that looks normal but might not actually be normal. And so that would be a situation where radiation, I think, obviously they preserve the breast. So radiation would have a role to controlling the microscopic residual disease.
So that might get rid of the Pagets. I'm wondering if it's a slow growing cancer, what is the average time from diagnosis to surgery?
Well, the main challenge with the slow growing cancer is getting it diagnosed to begin with, because if it progresses slowly, then and you do mammograms every year, it might take 4 years for that to become big enough to be detected on the mammogram as an invasive cancer, for example. If it's a more aggressive cancer, faster growing cancer, then it might appear between your mammograms. Like you have mammogram this year, it was normal, and 6 months later you find a lump that was missed. That can be an example. So basically there's a spectrum of the rate of cancer growth. Those that grow faster grow slower. And so, doing mammograms with some regularity allows you to find, things sooner. But once a diagnosis is obtained, say you have stage 1 breast cancer, then we generally recommend initiating treatment within 1 month of therapy. The latest would be 2 months of therapy, because there are data to show that there's a direct relationship between the time from diagnosis to treatment and survival. And certainly that time interval is more important for more aggressive tumors, but to some degree, it also might be relevant for less aggressive tumors. It's just that the time frame might be longer for those tumors.
Now, if you got a biopsy for Pagets, could anything else show up in it, or they'll just be looking for the Pagets? They wouldn't see anything else.
Right. So likely, if it's an earlier Paget's where the invasive cancer hasn't just grown up to the surface and this Paget's just covering it. So in that situation, if you do a skin biopsy, you might get invasive cancer as well. It's invasive cancer with Paget's. But setting that example aside, when they do a biopsy of the skin, likely they will only get Paget's, because the invasive cancer would not have progressed up to that level yet.
How does the presence of Pagets affect cancer staging? Is my cancer more likely to reoccur because I had Pagets even though I had a mastectomy of the breast?
So there's a phenomenon of staging where we stage a cancer based upon the highest stage component. Like you can have a cancer that has a stage 1 part, and you can have a cancer that has a stage 0 part. But in total, you'll be staged based upon stage 1. And we would just make a note, she also has some stage 0 present. And so the same approach applies to Paget's. If you only have Paget's and no invasive cancer, then your stage would be 0, which is the same stage as DCS. But if you have Paget's of the skin and an underlying invasive cancer in the breast, which would be, say, stage 1 or say stage 2, then you would be stage 1 or stage 2 with Paget's.
I was just diagnosed with Paget's after having some biopsies done. So far, it seems isolated to just my nipple, but they want me to go in for another mammogram and potential biopsy to be sure. And after that, I have to decide if I want a lumpectomy or a mastectomy and then radiation. You wouldn't have a lumpectomy or mastectomy for Paget's, would you? Or would you?
You could. So, but actually, this is also one other part of the last question that I didn't address. So, in that example, that patient had a mastectomy. So presumably, they remove the cancer completely from the breast, and by removing the skin and nipple of the areola, they have essentially eliminated the risk that she could have a nipple areola recurrence. And so that's just something to know about. But in this example, if there's a smaller area of disease in the breast, you can have a lumpectomy of that area. You just have to be thoughtful about how you manage the skin and nipple if they're involved with this Paget's. And so there is something called a central lumpectomy, CENTRAL lumpectomy, referring to the center of the breast, whereby we do a lumpectomy that removes the nipple and areola and the tumor underneath, but retain the rest of the breast, preserve the rest of the breast. And so since that's a breast conserving procedure, we would generally recommend radiation of the breast to reduce the risk of recurrence. So in this example, it sounds like they're doing the right thing. She's been diagnosed with a surface problem. They need to make sure she doesn't have an underlying problem. If it's an underlying problem that affects only one part of the breast, then she can be managed with a lumpectomy. If it's like the previous case where perhaps it was in multiple quadrants of the breast, then a mastectomy would be a more appropriate approach.
I guess my thought with this is, but then if it's only Paget's and nothing else, would you want to do anything that radical?
So I was just diagnosed with Paget's after having some biopsies. So far, it seems to be isolated to just a nipple. The operative thing is so far, but they want me to go in for another mammogram and potential biopsy to be sure. And so I think that is the right approach. That is, isolated Paget's is uncommon. That's like the 10% case. 90% of them have an associated cancer in the underlying breast, either behind the nipple and areola or farther back in the breast. So Paget's of the nipple and areola alone, if that's a diagnosis, is a diagnosis of exclusion. You have to exclude other conditions first, and then only once you have ruled out disease in other breasts, you can say, I only have Paget's of the nipple. So you have to be a little assertive, and not a little, you have to be assertive in making sure that the diagnostic workup is complete. Otherwise, they might remove the nipple and areola, and she'll come back 6 months later with the progressed cancer that was undiagnosed.
But if you're absolutely sure it's not there, you could just have the nipple removed and
right. And so my approach would be to start with the mammogram and ultrasound. If those studies are negative and I have what I suspect or have proven to be Paget's of the nipple and areola, I would then recommend an MRI, because an MRI has greater sensitivity for finding cancer, especially if the breasts are dense, or for example. And so, but I'm thinking that you have to go the one extra step to make sure that using the available imaging, you can't find disease. And obviously there's thermography and there's, other types of imaging studies of the breast, QT imaging, sonocyty. But the point is that you have to be thorough before you do surgery, so that you don't end up having to needlessly do surgery again in 6 to 12 months because of undiagnosed cancer. But every imaging study has limitations. Nothing's perfect.
Right,
So
that's why
we
you have to
accept-
do multiples.
Yes.
That's why I end up with a CT and a PET scan every 3 months at the moment. If you have surgery to remove the nipple, do you still need chemo and or radiation?
So it depends on the situation. Obviously, if it's isolated nipple patch, isolated patches of the nipple and areola, and if it can be excised with the clear margin, then there's less need for radiation. Although the data would say that some of those patients still do benefit from radiation, it probably is more an issue of the extent and the grade. Like if it's high grade these Pagets or low grade, and whether or not there's nipple duct involvement, like involvement of the surface, right under the surface, as opposed to just the skin. If it's just more limited to the skin and it can be excised with the margin, then you could argue that maybe it doesn't need to have radiation. But if it's high grade or it's large area or involves the ducts, then there's a greater need for radiation. And the other question was chemo. So Paget's disease, again, is like DCS, stage 0 breast cancer, and we don't treat DCS or Paget's with chemotherapy. If there is an associated invasive cancer, that invasive cancer can potentially be treated with chemotherapy if it's triple negative or HER2 positive or has some other high risk features, but we don't use chemo. There is, however, endocrine therapy, which we don't consider to be chemotherapy, but anti-estrogen therapy, which can be used to reduce the risk of recurrence if the Paget's is ER positive.
Or Herceptin if it's HER2.
We'd only use Herceptin if there's an invasive
it's
cancer associated, just like DCS. We don't treat DCS with HER2 unless there's also invasive cancer present.
If Paget's is suspected, why not just go straight to a biopsy? Why bother with an expensive MRI, which might or may not indicate Paget's? Well, I think you answered that. It's because you want to make sure there's nothing underneath it.
Right, because isolated Paget's is the less common presentation. Only 1 out of 10 patients will have isolated Paget's. That means 90% will have something underneath that you need to address surgically when the Paget's is addressed. So that's why.
I'm wondering if they know the reoccurrence rate of Paget's, and what is the reoccurrence rate of the nipple area only, and it's in the nipple area only and it's removed. And is the reoccurrence rate based on Paget's or other cancer found underneath in the breast tissue or both?
The answer is both, and primarily it's related to what's underneath. If it's isolated, like most skin cancers, even melanoma, can be treated by just excising the skin with an adequate margin if the disease is only present in the skin. Same thing with Paget's. If it's just in the areola and you can excise it with a clear margin and there's nothing else, then that's can be an adequate therapy. But the challenge is, what if there's more, and making sure that if there is more, that's managed. And generally speaking, if we have DCS involving the nipple ducts, along with the Paget's, and this is a kind of a high grade DCS, which is more common, then the evidence would suggest that would likely benefit from radiotherapy in addition to the surgical therapy.
Okay, what it's asking is, what is there a reoccurrence? Does Paget's, like, if
Right,
it's
so-
only Paget's by itself, is there much reoccurrence of it?
So the example, sorry, I got a little off track there. So the example is, if it's involving the skin and you excise it with an adequate margin, then the risk of recurrence is low. And therefore would not need to have radiation. If the margin is small, then the risk of recurrence is higher and radiation would be needed. So you can't quite say what the risk of recurrence is. It kind of reflects the situation. If there's disease underneath the nipple, the risk of recurrence goes higher if there's no radiation used. So you can't quite give just a sort of a single answer for what the risk of recurrence is. It depends upon the extent of the problem and the extent of the treatment, like how widely you can remove it.
Well, in my case, I had the HER2 underneath it. The Paget has never come back. It's been 4 years, but the HER2 did, so.
Right, so, but you had an excision of the, I say, of the, so the skin part was excised. And so it hasn't recurred in the skin, so that was a successful procedure in this example, with respect to managing the Pagets. And, you know, but if there's an invasive cancer part, then that invasive cancer part underneath can do what it would ordinarily do. It can spread to lymph nodes, it can spread to other parts of the body, it can spread within the breast. And so it has to be controlled as well as the Paget, which is why so much of the attention is focused on making sure there's not other disease present when you think there's only the nipple involvement, because the ultimate fate and prognosis depends upon the ability to control the underlying disease. That's the greater challenge.
Well, and in my case, it's like you said before, you need to be treated as soon as possible. I was 2 years out before it was treated, so it probably got where it shouldn't be before we even treated it.
But things don't necessarily stay static.
No, I had introductal
Intraductal papilloma.
removed from my breast. I've heard there's an increased risk of Pagets. Is there any truth to that?
I have not seen any reports, and I'm not saying they don't exist, but I've not seen any reports that indicate that there's an association between intraductal and intraductal papilloma and Pages. Now, to give you a little bit more context, an intraductal papilloma is essentially a polyp involving the ducts of the breast. They're usually present in the ducts that are close to the nipple. And so just like polyps in the colon may become cancerous and give rise to colon cancer. So you can have a polyp or a papilloma in the milk ducts that becomes cancerous and gives rise to a cancer that then extends up the milk duct to the skin and causes Pagets. But the vast majority, like well over 90% of intraductal papillomas have no cancer component to it. It has to be a cancer before it can give rise to the Pagets. And cancer of papillomas is very